Hello, future PTAs. I hope you guys are doing well. Today we are going to talk about aerobic therapy, aquatic therapy, and balance training. So aerobic exercise key terms, some of the things. So physical activity, exercise, physical fitness, maximum oxygen consumption, endurance, all these things we will talk about in future slides. Aerobic exercise training, which is also known as conditioning, adaptation, myocardial oxygen consumption, and deconditioning. Some of our definitions. Maximum oxygen consumption, or VO2 max, is the measurement of the body's capacity to use oxygen. Conditioning improves the body's ability to use energy by means of exercise. Adaptations are changes in the cardiovascular efficiency, endurance, and strength as a result of conditioning, and that it can occur in as little as 10 to 12 weeks of consistent exercise. And deconditioning is when your VO2 max decreases, your cardiac output decreases, your stroke volume decreases, muscle strength also decreases, all as a result of either inactivity or prolonged bed rest. And that can take as little as, deconditioning can start happening in as little as a week. Some of our energy systems. So we use the energy systems to convert ATP into ADP, which is then used for metabolic activity. And here's a YouTube video that I can put in the play posit. Hopefully I'll remember this week. And then muscles use this energy in order to contract. So there are three energy systems in our body: the phosphagen or ATP-PC system, the anaerobic glycolytic system, which is lactic acid system as well, or the aerobic or oxidative system. And we're about to go into each of those, what they are. So the phosphagen system, this is during your first 30 seconds of activity. This is your anaerobic system that kicks in immediately, doesn't need extra oxygen to supply it. The ATP storages from the muscle cells provide phosphocreatine as a fuel source, and it's used to perform short, quick bursts of activity. It provides great power, but it has very low capacity. It only lasts for about 30 seconds. I show somebody picking up a car. That's kind of a also a epinephrine thing, that there's some amazing chemicals going throughout their body, a fight or flight response to danger that allows people to do crazy things like that. But this system is replenished when the muscles are at rest, even though it quickly depletes. So this is the phosphagen system, or ATP-PC system. With the anaerobic glycolytic system, this starts around 30 seconds of exercise and lasts for up to 90 seconds of exercise. So from 30 seconds to a minute and a half, this one is the main one that's transitioning you from the phosphagen to the aerobic systems. It uses glycogen as its fuel source, and you are able to perform moderate activities, but still a short duration. This system breaks down 2 ATP into 4 usable ATP. So I thought I had on the last slide that the, here's the first one, the phosphagen system breaks down 2 ATP to 2 ADP. And then the anaerobic glycolytic system picks up and is able to use 2 ATP to create 4 ADP. It has moderate power and moderate capacity, only up to like a minute and a half. The lactic acid is the byproduct of this system, and of course lactic acid building up in the muscles will cause muscle soreness. And then the aerobic system, this requires oxygen to work, and the Krebs cycle is what is used here to use oxygen to convert 2 ATP into up to 38 usable ATP. And the good thing about this system is the byproducts of this system are used, it's like recycled. So it is, that's why it's a cycle and a circle. As things are being shot out, those things are reuptaken. My word choices are not great today. So as things are being, byproducts are being produced, it's able to use some of those byproducts to continue the cycle. So it kind of sets itself up to constantly regenerate. And it starts around 2 minutes of activity, and then it continues throughout the entire duration of your activity. So this is more your endurance type of system. And the reason it starts 2 minutes in is your breath has to kind of catch up, and you have to start breathing a little heavier in order to allow enough oxygen to kick this system into gear. The mitochondria, this is the cell powerhouse. It resynthesizes the ATP through the Krebs cycle so that it can constantly keep going. This has a great capacity but smaller power, so not as much strength and quick, sudden movements, but it lasts so much longer. I have a little blurb about the Krebs cycle below that you're welcome to look at, and there's probably some great videos. I might be able to find one and send it to you about the Krebs cycle as well. But with the Krebs cycle, pyruvate, which is derived from glucose, is oxidated. Oxygen is added to it. It produces acetylcholine, and then this is broken down into several byproducts through breathing that'll release through breathing, like carbon dioxide. Then the electron transport chain combines the electrons from some of these byproducts to form ATP and GTP, which is used in the same way as ATP, and this is through oxidative phosphorylation. Acetylcholine is a byproduct of the system. This provides initial ingredients for the starting point of the cycle, which allows the cycle to continue and it to be a constant cycle. So the byproduct of acetylcholine is also kind of a starting point of a new cycle, and the byproduct of NADH2 and FADH can form into more usable ATP, and that's why it keeps going. But the oxygen must be coming in and the carbon dioxide must be being released in order for this to continue working properly. That is the Krebs cycle, explained as quickly as possible. So recap of the three systems and when they kick in. The phosphagen system kicks in immediately and then kills out within about 30 seconds. The glycolytic, we call it the anaerobic glycolytic system, kicks in about 30 seconds in and then lasts up to about 90 seconds of activity. The oxidative is very slow to kick in, but by about 2 minutes of activity, it is going pretty full force and continues throughout the remainder of your exercise. Motor unit recruitment. First, we recruit fast twitch, which is type 2B fibers that are recruited first. They are anaerobic in nature. They are low in myoglobin and mitochondrial cells, which are used in aerobic metabolism, but they're high in glycolytic and power capacity. So they don't really use oxygen, but they use the glycogen and are perfect for that phosphagen or ATP-PC system. Then the fast twitch fibers that are type 2A can be recruited for both aerobic and anaerobic activities. They are high in myoglobin, but they're also high in mitochondria. They are quick to contract, and they have characteristics of both type 1 and 2B fibers. So they're kind of the cross bridge, which is that middle system, the anaerobic glycolytic system, which kind of starts a little bit later and kind of transitions from anaerobic to aerobic metabolism. And then the slow twitch are our aerobic fibers. They're type 1. They're recruited during endurance activities. They're really rich in myoglobin and mitochondria. Those are things that are used for the aerobic metabolism. And they have slow contractile properties, but they're resistant to fatigue. So it takes a little while to warm these fibers up, but once they get going, they keep going until you need to stop. They are high in oxidative capacity, meaning they use a lot of oxygen, and low in anaerobic capacity. They can't do very much work without the use of oxygen. The physiological response. So exercise pressure response is when the sympathetic nervous system responds to skeletal muscle contractions, and it reflexively causes the peripheral vasoconstriction, so in non-exercising muscles. So it's saying, hey, we need more blood to come here, constrict the areas that are not being used right now, and then dilate the areas that are being used. Now this constriction to like the organs or certain organs, you need your heart, of course, and to unused muscles at the time, leads to an increase in the blood available to the muscles being used and to the heart. So it increases your cardiac contractility, so your heart's ability to contract and work. It increases your heart rate. It increases the stroke volume. Your systolic blood pressure increases, and this increases and redistributes your cardiac output. So it's a system that, this is the exercise pressure response, that as your muscles start working, more blood is pushed to those muscles and redirected from other muscles that aren't being used. So if you're running, more blood's going to the legs primarily, maybe a little bit to the arms, not so much to some of the organs that aren't working right now, not so much to the face. And so the blood is redistributed so that the muscles that need it the most get what they need. And the degree of the response depends on the muscle mass and the intensity of the exercise. Some of the effects on the cardiovascular system, as we talked about, it increases heart rate and it increases your heart's ability to create force, the amount of strength from and contractility from the heart. So this same system is what acts in our fight or flight response, in response to fear, danger, and other increased demands on the body. And it can release hormones that increase your heart rate and your level of alertness, and sends more blood to those muscles so that you can either stay and fight or run away. So it's kind of the same thing that happens when we elicit the exercise pressure response. The same system is being elicited as the fight or flight response. Okay. More physiological effects. So peripheral effects, when you're exercising, there's a generalized vasoconstriction. So remember, blood is being redistributed to the muscles that need it and away from things that don't. And it shunts blood from non-working muscles and organs in order to deliver the most blood to the areas that are needed. So vasoconstriction occurs in all the veins, which increases venous return. So the arteries are restricted in a certain pattern depending on what muscles need the blood, and then the veins are restricted in order to send the blood back to the heart more quickly, so increasing venous return. Specific vasodilation occurs, so the muscles that need it the most, including the heart, those blood vessels dilate to send more blood to the area, and this also increases the availability of the components that cause muscle contraction, so intercellular magnesium, calcium, ADP, and PCO2. This causes a net reduction in total peripheral resistance. So as some vessels constrict, others dilate, and there's overall a reduction in the resistance from the arteries. But there's also a slight vasodilation to the skin to allow more heat to be released from the body. So again, kind of a quick overview. Vessels going towards organs that aren't being used or muscles that aren't going to be used constrict and get smaller and decrease the amount of blood flowing to them, versus other vessels dilate and get bigger to the muscles that are needed and also to the skin in order to provide more blood for the muscles that need it and in order to release heat from the skin. Also, when we work out, so increased muscle metabolism can cause an increased amount of oxygen extracted from the bloodstream, from the arteries, and an increase in cell metabolism metabolism, increases the carbon dioxide pressure, PCO2, and the hydrogen. Hold on. Okay, I'm sorry about that. My phone was blowing up, and anyways, I was talking about PCO2, which is the partial pressure of carbon dioxide. So it's how much is available within the arteries and veins. So as we're working out, the response is an increase in cell metabolism, which increases the amount of carbon dioxide within the bloodstream and hydrogen as well. It increases the body temperature. There's a release of certain hormones, including epinephrine, and stimulation of joint and muscle receptors. All of these lead to stimulation of the respiratory system, which increases your respiratory rate and how much oxygen is available for these systems. So your ventilation is increased, how much you are breathing per minute, and then your alveolar ventilation, so that's how much gas is exchanged at a cellular level. Diffusion of the gases across the cell membrane, that increases. So not only are you breathing more, bringing more oxygen in, more oxygen is being absorbed by the tissues and on a cellular level as well. And then gas exchange increases typically within the first 1 to 2 breaths, but it typically takes a minute to 2 to really increase enough to be ready to kick in that aerobic metabolism. Increase in oxygen is supplied to muscles by an increase in blood flow, an increase in oxygen extraction, which we talked about, more oxygen is being removed on a cellular level, and increased oxygen consumption. So all of those things increase the oxygen that's available to the muscles that are working. Respiratory acidosis and alkalosis we are going to talk about because I know there are board questions about that. And so I wanted to add that in just to talk about what that is. So carbon dioxide is an acidic product, and it starts to build up in the bloodstream as we exercise. So as it builds up, the pH becomes more acidic. Carbon dioxide is an acid. As it builds up, it becomes more acidic. In healthy individuals, this should provoke an increase in respirations in and out. So you want to be breathing more carbon dioxide out to release it out, which in turn, if you're breathing faster, increases the amount of oxygen available. So it's actually the change in the carbon dioxide within the bloodstream that provokes more changes in your respiration than the change in oxygen levels itself. If the respirations do not increase, then respiratory acidosis starts to happen. So the blood becomes too acidic. Some of the signs of this are headache, shortness of breath, tremors, confusion, add more if needed. I don't know what that's there for. Sometimes I write stuff and I don't know what I'm talking about. But pace breathing sometimes can help if they're breathing too much off. So with carbon dioxide is acidic, as it builds up, you breathe it off. But if you breathe too much off, then you actually go to the opposite end, respiratory alkalosis. So you could do pace breathing. If you're not breathing enough off, trying to really do a forced exhalation can help do that as well. So normal values for oxygen and carbon dioxide partial pressure is for oxygen 75 to 100 millimeters of mercury, for carbon dioxide 35 to 45. And then normal blood pH, I do want you to write this down because there's a lot of board questions on the blood pH was this, what does it mean as far as acidosis versus alkalosis. So 7.35 to 7.45 is your normal blood pH. If the blood pH is higher than 7.45, then that's a more basic blood. The higher the pH is, the more base that's in there, or the less acid. The lower the pH, the more acidic the blood is. So if you're in respiratory acidosis, then it would be less than 7.35. If you're in respiratory alkalosis, to much base or not enough acid, it's above 7.45. So please write those down and understand those. More normal blood values, I just kind of put them down here, just exactly what I talked about in the last slide. And with respiratory acidosis, the blood pH has decreased, become more acidic. The carbon dioxide has increased. It's an acid, so there's too much in. But the bicarbonate, so HCO3 is bicarbonate. The normal values for that is 22 to 26. That is remained constant because all that's changed is your blood pH. Now, if you have it consistently over time, let's say you have a respiratory disease like COPD or asthma, emphysema, and your blood pH is off continuously, chronically, then your body will start to compensate. And so it will release bicarbonate as needed, either release more or less will be released in order to rebalance out the blood pH. So if you you're just exercising too much or you're just holding your breath too much and your blood pH is just starting to be thrown off, the pH values and the carbon dioxide in the blood will change, but the bicarbonate will not change. Over time, if you continue to have that same issue, the bicarbonate will be either stimulated to release more or less in order to compensate and normalize the blood pH, even though your breathing is still not normalized. Stress testing. So stress testing is done to look at your heart rate and rhythm in order to assess your heart's function during activity. So typically people will walk on the treadmill. They'll have some leads connected to them and someone will be watching their heart rate and the heart rhythm and seeing how it changes with increased activity. They use this to diagnose heart problems and to determine if it's safe to exercise. They also use it to see what type of treatment is needed and what type of parameters to use as you're treating a patient with heart problems. And the principles of it are as you vary workload, you start low and you progress, and you maintain each workload for at least a minute, and then you measure the VO2 max and you stop if there's any abnormal findings as far as the oxygen rate drops too much or if they start to get symptoms like lightheadedness or dizziness or anything like that. And before a stress test, they still need a physical exam to clear them and say they're healthy enough to even do a stress test. And throughout a stress test, an ECG is typically used to monitor their heart rate and rhythm. These are performed by medical doctors. Occasionally, PTs might perform it in a specialized cardiac clinic, but typically it's the MD that will perform a stress test. But when they come to your clinic with heart issues, they may have values or information that has been taken from the stress test that's already been performed. These are some of the reasons you would stop a stress test. If they start to get heart pains, if their blood pressure, systolic blood pressure drops too much, or if their overall blood pressure increases too much, if their heart rate does not increase despite increased demands on the heart, their heart rhythm changes, if the patient asks to stop, they just don't feel good, or if they have any of the symptoms, lightheadedness, confusion, pallor is like pale skin, losing the color, cyanosis, that's that blue around your mouth, nausea, shortness of breath, peripheral circulatory insufficiency, if they start, their fingers or something start to go white or blue or get numb, wheezing, leg cramps, or severe fatigue. All those would be a reason to stop a stress test. And if any of those symptoms occur while a patient's doing exercise in your clinic, they also need to sit and rest, especially if they have heart problems. What does the heart do in response to exercise? In healthy people, the relationship between the myocardial oxygen supply and demand is maintained during exercise. So as the body needs more oxygen, that means the demand goes up, the supply also goes up. If somebody has cardiac failure or is significantly deconditioned, the loop shortens and becomes more narrow, so their body is less able to their heart is less able to adequately fill and eject the blood. And this can lead to ischemia, so decreased oxygen available for the muscles, especially the heart itself, which would cause chest pain if the heart does not get enough oxygen, because there's just not enough time for the blood to perfuse. It's just the system is not adequate, and so the blood that's pumping through is not actually perfusing through the heart. The heart is pumping too fast, and the supply is not keeping up with the demand. With an exercise program, typically every patient is going to have their own frequency, intensity, all that stuff, just depending on their needs. Now, I have it in another lecture that if a person is able to do at least 20 minutes of continuous activity, then the prescription or the frequency should be 3 to 5 times a week that they do at least 20 minutes of physical activity. If they're not able to do 20 minutes straight, then it's recommended for them to do short spurts every single day. So if all they're able to do is 10 minutes, then do 10 minutes twice a day until they're able to increase the time to 20 minutes. So every day they should total 20 minutes at least of physical activity, but it might be in short spurts, in 5-minute increments or something like that. One of the ways I tell patients to do this is every time you get up to pee, walk a few laps around your house. Every time you get up to eat, walk for 5 minutes. Things like that, just functional things that remind them, okay, it's time to walk and get some of my exercise in. The intensity, once you know their VO2 max, then 50 to 80% of that VO2 max yields the best conditioning response. Remember, in order to improve muscle strength, you must overload it, like the overload principle we learned about. So you still have to push the heart muscle to work a little bit harder than it's used to working in order to make it stronger. And then if a patient's able to do high-intensity exercise or long-duration exercise, that is going to lead to the training effect occurring faster than if they're doing short, low-intensity exercise. Rule of specificity: train for your desired activities. If you want to get better at cycling, then you need to ride the bike. The rule of reversibility: if you stop doing what you were doing, you start to lose the effects or the benefits of conditioning within 2 weeks of inactivity. And I've seen studies that say as little as 1 week, but certainly within 2 weeks of stopping what you're used to doing, you can start to decline in your overall conditioning. Some of the guidelines: we want to typically warm somebody up for 5 to 10 minutes to get the blood pumping and the oxygen supply starting to meet the demands. With aerobic exercise, ideally that you want them to do 20 to 60 minutes consecutively. Continuous training, interval training, circuit interval, any of that is acceptable. And then a 5 to 10 minute cool down period. Effects of conditioning: conditioning over time will decrease your resting heart rate, and it will actually decrease your heart rate within the activity. Your heart becomes stronger and more efficient, so it doesn't have to pump as hard to get the same results. There will be a decrease in calcium excretion, so your body reabsorbs more calcium, which helps maintain strong bones. There's an increase in the stroke volume at rest, so your heart is able to push more blood out with every pump. There's also an increase in your cardiac output, how much blood is leaving the heart each time, in your ventilatory function and capacity, your ability for your body to take oxygen in and then diffuse oxygen across the tissues. And then an increase in your mitochondrial enzymes and your energy stores, and a decrease in anaerobic system usage during activity. So your body starts to kind of get used to doing the exercise and quickly snap you into the aerobic exercise more quickly. Okay, effects of deconditioning. If you don't use it, you lose it. So decreased blood volume, which leads to orthostatic hypotension. So like if somebody's on bed rest for a while and then they start to get up, they'll get more dizzy, might get some floaters in their eyes or everything go black for a minute. That's orthostatic hypotension, is a drop in the blood pressure. Everyone, when they change from laying down to sitting up or sitting up to standing, has somewhat of a drop, but if it's more than a specific increment, I think it's like 10 millimeters of mercury or 20, then it's considered orthostatic hypotension, and that's when some of those symptoms like dizziness and lightheadedness and things will occur. Decreased blood volume in itself can create dizziness. It can also create tachycardia, which is a rapid heart rate. Your body, your heart responding by increasing the heart rate speed in order to keep up. Syncope, which is fainting. The other effects of deconditioning: a decrease in work capacity due to limited oxygen max and oxygen uptake and limited ability to use the oxygen efficiently. The decreased plasma and red blood cells leads to a limited oxygenated blood circulation, and decrease in lean body mass leads to decreased muscle size and strength, and an increase in secretion of urinary calcium leads to poor bone mineralization and density. So if you don't use it, you lose it, and all the effects of conditioning, all the benefits, you lose those and your body starts to decline. Guidelines for healthy children. So children and adolescents should accumulate a minimum of 1 hour of physical activity every day, as just moving around, PE, sports, free play, planned exercise, all of that combines to go into their 1 hour a day. These activities should combine moderate and vigorous intensity activities. The moderate intensity is defined as an activity that increases breathing, sweating, and heart rate. Vigorous activity substantially increases all of those. So kids should be running around and climbing trees and jumping and doing high-intensity things throughout the day. For a healthy adult should get at least 150 minutes of moderate intensity exercise every week. So if we're looking at 50-minute increments, that would be 3 times a week. If we're looking at 30-minute increments, that would be 5 times a week. Exercise recommendations can be met through 30 to 60 minutes of moderate intensity exercise 5 days a week, 20 to 60 minutes of very high intensity, vigorous exercise 3 days per week. And one continuous session and multiple shorter sessions of at least 10 minutes each are both acceptable. So if somebody cannot get to the 20 minutes or they just can't find time, if they stand up and walk or do moderate to intense exercise at 10 minutes at a time, several times throughout the day, those you can accumulate to equal your 150 minutes per week. Gradual progression of exercise time, frequency, and intensity is recommended, but for best adherence and least risk of injury. So you don't want to go from couch potato to marathon. If you're going from couch potato, first start a walking regimen and then start more running or just slowly progress. And then people who are unable to meet these minimums can still benefit from some exercise. So like I said, even if they can't walk 10 minutes, if they just get up and walk an extra lap or two every time they go pee, that's still going to help increase their endurance and their heart's ability to take on demand so that eventually they can tolerate 10 minutes of activity. One thing I want to say about the children, remember we learned last time, but you don't really want to do resistance exercises in adolescence before puberty because it's too much stress on the bones and can stunt the growth. Just a reminder of that. Guidelines for older adults. So older adults can safely participate in regular exercise. Regular physical exercise has been shown to elicit a number of favorable adaptations that contribute to healthy aging, including not losing your strength or your power as quickly, continued balance, continued overall general health. Endurance training can help maintain and improve various aspects of their cardiovascular function as measured by the VO2 max, their cardiac output, and the oxygen difference as well as enhanced sub-maximal performance. So help them to actually get in better shape. Strength training also can offset the loss in muscle mass that happens as we age and strength that are associated with normal aging. Remember, if you maintain a healthy lifestyle, you can kind of counteract those results of aging. All right, so we're going to switch gears here and go to aquatic therapy, which I love, and just the benefits of aquatic therapy. So if you have questions, make sure you reach out to me about the aerobic capacity and aerobic endurance and all those things. Reach out and let me know. With aquatic therapy, this uses water to facilitate therapeutic interventions. Some of those you can use in the water are range of motion, strengthening, stretching, endurance training, joint mobilization, gait and balance training. All of those can be done in the water and be just as effective as on land. Some of the benefits of doing it in the water is you can have increased range of motion and strength. You can facilitate weight-bearing activities, so the buoyancy kind of keeps an upright position and helps offload some of the weight, decreases the pressure on the joints while still allowing them to weight bear. It can enhance your ability to use manual therapy techniques depending on what techniques you need to use. It provides you 3D access to the patient. You don't have to constantly say, now lay on your stomach, now roll to your back. You can walk around them and access what you need. There's cardiovascular benefits. You can replicate functional activities easily. There's a decreased risk of injury because it's more easy on your joints, and an increase in your relaxation when you're in the water. Some of the properties of water that help make this possible are buoyancy, hydrostatic pressure, viscosity, surface tension, and hydromechanics, and we'll go into each of those now. So with buoyancy, that's that upward force that opposes gravity on a thing that's emerged in body. The effects on the body, it's easier to move because it makes you relatively weightless and it unloads your joints. It also provides resistance. Water buoyancy provides resistance in all directions. Buoyancy changes based on your body's composition. So if you have more air in your lungs, buoyancy increases, makes you more likely to float. If you breathe all that air out, buoyancy decreases. You're more likely to sink. The more fatty tissue you have, the more likely you are to float. The more bone mineral density, the less buoyancy you have, so the more likely you are to sink. And then higher volumes of lean muscle also make you more likely to sink. So my dad, we used to always laugh because he used to, when he got in water, he would always sit on the bottom like that. He was always very muscly and dense, just very dense. And he would sit and we would count how long he could just sit there on the bottom of the water, or of the pool, but he could not float. To save his life, he could not float. All right, the center of buoyancy, so it's kind of like the reference point, similar to the center of gravity on land, but this is when you are in water, and so it's the point where vertical forces are predictably active on the body. In a vertical position, it's at the sternum. If you're standing on the pool floor, the center of buoyancy and center of gravity are both active, but if you're in deep water, only the center of buoyancy is active on your body. Flotation devices placed behind the patient can cause them to lean forward. And then if they're placed in front of the patient, they can cause them to lean backwards. So some of those flotation devices, I noticed some of the life vests for infants have this extra flap on their head to keep their head from sinking, but it can also push their body forward. So you have to be careful what flotation devices you're using and then where you're placing those. Weight bearing related to immersion level. So as you are submerged deeper and deeper in water, there is less and less weight bearing on your legs because of the water buoyancy. So if the water is just to your hips, your ASIS, about half of your body weight is against gravity. And so about half of your body weight is how much you are bearing weight. So if they have a weight bearing restriction of, let's say, partial weight bearing less than 25%, we'll say, then they could not be in the water this low. They would have to be in water to their shoulders or or higher. If the water's even with the xiphoid process, your weight bearing about 33% of your weight, and if it is up to C7, then you're only bearing about 10% of your weight. Hydrostatic pressure, that's the pressure exerted by water on immersed objects. It increases the further an object goes away from the surface. And some of the effects on the body is it could decrease effusion, decrease your joint swelling. It could increase venous return because the pressure pushes that fluid back to the heart. It can decrease your heart rate, and it can centralize the blood flow to the chest cavity. So less blood is going to the extremities and more to the chest cavity. And if you go down too quickly and come back up too quickly, there is kind of a shift in your hydrogen within the body, and that can be a little bit dangerous as well. So you have to be careful how quickly you go down and up if you're like a deep sea diver or something like that. Viscosity is the amount of friction occurring between liquid molecules, and this results in resistance to flow. So the effects on the body, it increases the resistance with higher speeds of movement. If you're moving faster, there's more resistance going against you, and there's increased resistance with increased surface area, which is why somebody might put gloves on or something to use almost as a weight to increase the resistance with aquatic therapy. Sometimes they'll use those paddle boards and push them down and up as a weight as well, because it increases the resistance, the more surface area that you're pushing against the water. So viscosity is the friction between the water molecules rubbing together. The faster you're running, walking, swimming in water, and the more surface area that you're going against the water, the more resistance is provided. Thermodynamics. These are the effects the water temperature has on the body. The specific heat is the amount of heat required to raise the temperature of 1 gram of substance to 1 degree Celsius. And the temperature transfer, as a patient moves through water, they lose heat more quickly than staying in one place. And remember, water conducts heat 25 times faster than air. This is why we use moist heat packs. This is why we also use liquid ice, like ice massage works faster than just a regular ice pack that's gel. The water itself conducts heat much faster than air. Water also penetrates deeper. So if you're cold and you're outside and you want to warm up, you could warm up a lot faster taking a hot shower than you could just going in and laying under some blankets. Water temperature for aquatic therapy should be between 78.8 degrees Fahrenheit and 98.6 degrees Fahrenheit. It should be pretty warm. You do not want to jump in some ice cold water. And always monitor the patient's vitals and their rate of perceived exertion throughout treatment. Typically, when they're in the water, it's hard to monitor vitals, so often we use the rate of perceived exertion, and then if it falls too low, we immediately will get the patient out or get them to a place where we can assess their vitals better. So if you're in colder water, it can help people who have spasticity, acute joint inflammation, those who are deconditioned so they don't overheat, and then help people with general flexibility, strengthening, and gait training. In warmer water, acute musculoskeletal injuries, chronic joint inflammation, warm water can help decrease muscle guarding and stiffness and help with pain. The air temperature around should stay about 3 degrees greater than the water temperature as well. Some of the goals for aquatic therapy. So provide an environment that increases functional recovery through augmenting the ability to perform interventions. So all you're worried about is, what do we need to do functionally? The water is just a tool we can use to help increase the function. Some of the precautions: if somebody has a fear of water, then aquatic therapy may not be best. Neurological disorders, just depending on their level of consciousness and things like that, may have to use your judgment there. With respiratory disorders, remember, water increases venous return. If already the respiratory system can't keep up or the heart can't keep up, like cardiac disorders, then you have to be cautious about using water because it may overwhelm a system that's already overwhelmed. If they have open wounds, absolutely do not take them in the water. They're at a high risk of infection and spreading that infection to others as well. And then if they have lines like IVs and things. Now, sometimes you can with a catheter. If they have an in and out catheter, you can take it out. Some certain wounds, you can get certain dressings that are waterproof that you can cover. So it's a precaution because you may have a way around it, but in general, those patients, you need to be cautious about doing aquatic therapy. Contraindication: if they have severe peripheral vascular disease, if they have danger of bleeding or hemorrhaging, if they have an uncontrolled bowel or bladder, if they have menstruation and they don't have a tampon in, if the water, if they have a waterborne or an airborne infection or disease that could spread, if they have uncontrolled seizures, if they are developing cardiac failure, unstable angina, decompensated congestive heart failure, vital capacity less than a liter, open wounds without a dressing over them, colostomy bag, or skin infections like ringworm that could spread through the water. All those you would avoid aquatic therapy for the protection of the patient and others getting into the pool. Different types of pools. Some clinics have little small chambers that fill in, that the patient walks in and then they fill up, and then before they walk out, they drain. That's common in some of the clinics. Some have a larger underground pool type, and others have kind of a sitting on the ground chamber of water that they can use for aquatic therapy. I've seen all kinds of different pools in the clinics, and any that do the job are just fine. Some of the equipment that we like to use. So we can use weights in the water. We can use, look, she has weights on her feet and then a floaty device on her stomach to keep her up. We can use here some of those like paddle boards, boogie boards that I use sometimes for arm strengthening and ab work and things. Pool noodles can be used as well. Anything that increases the water resistance can be used, or decreases. There's just depending on your desired effect. If you want them to be more buoyant or more resistant or whatever. Here is how we monitor the rate of perceived exertion. I prefer the 1 to 10 scale, and I also prefer one that has the pictures on it, because a lot of people have a really hard time giving you a number on the 6 to 20 scale, and they have a hard time just picturing it in their head. So one with pictures is ideal, and a lot of times in places that have aquatic therapy, they'll have something like this hanging on the wall, and they'll ask the patient throughout, what number are you now? Some of the exercises, pretty much most exercises that can be done on land can be done in water. You just may have to change how you're doing them. You can change the water height. You could change how the flotation device is used. Any of that you can change to alter the exercise, but most exercises that can be done on land can be done in the water. Now we're going to switch gears and go to balance training. So with balance training, the center of mass is very important. That's the point at which the body is in perfect equilibrium, versus center of gravity is the vertical projection of the center of mass to the ground. It typically is slightly anterior to S2. Remember, momentum is mass times velocity, and your base of support is the perimeter of contact between the body and the floor. A wide base of support gives you more stability. A narrow base of support challenges your balance. Limits of stability. That's the ability one has to sway and maintain equilibrium before changing their base of support. So ability to move within that base of support before they need to change their foot placement. Balance training challenges their limits of stability in order to improve their dynamic stability. Some of the balance systems, we have 3 systems in the body that help us balance. There's the somatosensory system, which is the muscles in your legs, and it gives you information on your body's position and motion. And really your muscles everywhere, but primarily the ones in your leg give you the most feedback for your balance. The visual system, which is from the eyes, where you have information on your position, your movement relative of your head relative to its surroundings, so head movements. And then vestibular is feedback from the inner ear that gives you feedback on position and movement of the head in space with respect to gravity. So somatosensory is talking about muscles in your leg. Vision, you know. Vestibular is the inner ear. Types of balance, there is static balance, which means no movement. Dynamic means you're moving. And then automatic, which is postural reactions that happen as a result of unexpected changes in the environment or perturbations, so like pushes. So if you're standing on a moving bus and all of a sudden they slam their brakes on, then some automatic responses will kick in to help you stay balanced. Motor strategies for balance. We have the ankle strategy, which is the muscles in your foot that kind of make really slight adjustments to help you stabilize. Your weight shift strategy, that is typically in the lateral plane, shifting your weight from your left foot to your right foot in response to external forces. And we see this a lot in walking. Then there's this suspension strategy, that's bending the knees to quickly lower your center of mass. So that seems like when you land after you jump, you quickly bend your knees to kind of absorb that shock. There's the hip strategy, which is bending your hip in response to rapid large perturbation. So it's a rapid bending of the hip in different directions in response to a big sudden change. And then stepping. If there's too large of a force for you to maintain your center of mass within that base of support, then you are going to step in order to maintain your balance as you are outside of your limits of stability. Now, most of the time as we're balancing, as we're standing, we're using combined strategies. There's a lot of different strategies put together to help us stay upright. Impaired balance. So proprioception may be impaired in patients who have recurring ankle sprains, who have knee ligament or meniscus damage, who have degenerative joint disease, low back pain or dysfunction, diabetes with peripheral neuropathy. Vision might be impaired in patients who have low vision or decreased visual acuity. Peripheral field cuts, which is like this, where there's a portion of the area that they're just not seeing, either because of eye damage or most of the time because of neurological damage, a damage to the part of the brain that interprets that data. People may have decrease in depth perception. They may have had a brain injury or a stroke or any type of neurological injury that might affect the eyes. And then diseases like cataracts, diabetes, multiple sclerosis, all of those affect vision as well. Somatosensory integration may be affected in patients who have damage to their basal ganglia, their cerebellum, or other motor areas of the brain, like patients with a brain injury or a stroke. And these are some of the areas in the brain that help you balance. So if those are impaired, then your balance will also be impaired. Some medications also induce dizziness and decrease your muscles' reaction time. So you have to be careful with patients who are on medications and be familiar with what they're on and what the side effects are. And then impulsivity. A lot of times patients who have had a brain injury or any neurological issue will be impulsive, which means they don't think it through. They just automatically respond to whatever comes up in their brain. And that can obviously decrease balance and awareness of balance deficits for somebody to be more cautious. Vestibular dysfunction. So all of the following can be damaged or can damage vestibular function and lead to balance deficits. So we'll learn about some of these more in depth in Rehab 2 as we talk about vestibular dysfunction. But BPPV is when the crystals inside of your ear have become misplaced and you get dizzy as you turn your head. Meniere's disease, a fullness in your ear that can rupture your eardrum and cause severe dizziness. Mal-day debarkment, that's like if you've been on a cruise and then you get off and you still feel like you're swaying. Your brain has changed the input based on trying to forget about the swaying, and then it's once you are not swaying any longer, you continue to feel that difference in input. Vestibular hypofunction, that's just when over time less input is coming from the vestibular system. That can happen as we age, especially if we are not remaining active. Aging in itself can decrease the activity of the vestibular system, but primarily because people aren't using it as much. And if you don't use it, you lose it. And then medication. Meclizine is a medicine that's often given due to dizziness, but if you take it, how it helps you with dizziness is it paralyzes the hair cells inside of your ear. And those hair cells are supposed to respond to movements to give your brain feedback on where your head is in space. But if you take meclizine more than 3 days straight, those hair cells may be permanently paralyzed, which means you will permanently have vestibular hypofunction. You're permanently getting less input from the vestibular system, which can create more dizziness or balance issues more than anything. Vestibular schwannoma or acoustic neuroma, those are tumors on the vestibular nerve or the acoustic nerve. Stroke, vestibular neuritis, that's just inflammation of the vestibular nerve, and then traumatic brain injury. All of these can damage your vestibular system and cause it not to function appropriately. Fall risk and aging population. Falls are common among the elderly for so many reasons. Some is because they are slower with initiation of movement. So remember, power affects the ability to stay balanced more than strength. So if somebody is strong but not able to quickly move, then they may be more likely to fall than somebody else that has the same strength but the ability to move fast. Typically, older adults use more hip strategies because they have a decrease in their limits of stability, especially anteriorly and posteriorly. Typically, we have decreased speed or use of motor strategies, so it takes them longer to react to the external force. A decrease in anticipatory postural control, so that's your internal forces that kind of bear down and stabilize you before the bus starts to slow down or before you walk past somebody that is really close to you and you feel like you might bump into. And then a decreased ability to divide tension or do dual tasking. Oftentimes, when you have balance risk or balance deficits, you have to focus so much on the balance itself that if you start talking or carrying something while you're walking, you immediately lose balance because you're not able to focus as much on it. And then a fear of falling. Fear of falling is a huge thing in the elderly population. They see somebody fall, break a hip, get hospitalized, and end up in a nursing home, and that scares them, so they change the way they walk in order to try to avoid falling. And what they typically do is keep their legs on the ground, keep their feet on the ground, and kind of shuffle, take smaller steps. Well, when you take smaller steps, you have a smaller base of support, and you're more likely to fall. When you shuffle your feet, you're more likely to trip over anything in your pathway because you're not picking your foot up and clearing the ground. So the changes that they make to the gait, and it may be kind of subconscious, they probably wouldn't tell you that they're doing that on purpose, but once you get down to the root of the problem, that is what they're doing. But the changes they make actually make them more likely to fall. And then if somebody has falls, it typically, increase falls, comorbidities, and reduced independence with activities of daily living lead to premature admission to assisted living facilities. So like I said, oftentimes that's kind of the start of the end, and people see that with their friends. They get scared of it, and they have that fear of falling because it's true. When you fall and you can't get around independently, then you're more likely to be admitted early into an assisted living facility. Assistance levels, we'll go over this in class: maximum assistance, moderate assistance, minimum assistance, contact guard assist, standby assist, supervision, and independent. Independent, you don't need any help. Supervision, somebody can watch you from across the room because you're pretty safe. Standby assist, they want to be right there just in case you go off balance, but they don't have to be touching you. If you're touching the patient at all, that's contact guard assist. Min assist, you're offering about 25% help, 25% of their body weight. Or even if you're just repositioning one limb, like the leg, as they're walking, then that's min assist. Moderate assistance, you're assisting with between 25 and 75% of their body weight. And maximum assistance, you are assisting with 75% or more of their body weight. Balance assessments. So some of the assessments we use to determine if somebody is at a fall risk is the timed up and go, the Berg balance scale, the Tonetti balance scale, and the dynamic gait index called DGI. And I have a video for each I can put on the play pause it so you can watch them if you want to. But ideally, as a PTA, you need to be familiar with what these are and what the results mean so that you know if somebody has a score of 18 on the Berg balance scale, does that mean they're at a high fall risk or not? And how close are they to reaching the next category? And what activities do we need to work on? Especially in home health, but also in some rehab settings, the home environment is typically assessed by the PTs. So you go and you look at what changes do we need to make to help the patient avoid falling. Many of the recommendations are to remove objects in the pathway. For example, if somebody had a walker, they could not successfully walk and sit on the couch with this coffee table here, so moving that. Removing throw rugs because they are a trip hazard. Placing night lights along the pathways to the bathroom, especially those that are triggered by movement. So as soon as you get up, it comes on. Rearranging furniture to make sure the assistive device fits everywhere you need to go. Adding grab bars in the bathroom or rails by the stairs to make sure they have use of their hands for balance. Using non-skid bath mats to decrease the slickness and ability or the likelihood of falling. And then making sure carpet is not so thick that it kind of is easy to catch the foot on, so less than half an inch thick. Some of the balance training we'll go over in lab for sure, but some of our common exercises are sitting balance, standing balance, static, dynamic, gait training, assistive device training, and stair mobility training, fall recovery, which is something we can do to teach the patient if you do fall, here's what you do. Gaze stabilization, that's more to challenge the vestibular system and eye movements to get them stronger and be less likely to have blurred vision when you move your head. And then there's many programs out there that target older populations and fall risk. So Otego fall prevention, Tai Chi, aquatic therapy, and vestibular rehab therapy. So all of those you can check out and apply to your practice as well. Proper lifting mechanics. Make sure that you pull the object close to the body, that you bend at the knees and not the back, that your base of support is wide, and that you avoid trunk rotation. This is just to avoid injury. We talked about this in patient care skills, so you should be familiar with it. But just a quick reminder because that was one of the objectives I needed to cover in this lecture. All right, if you have questions for me, please reach out. I will see you in lab. Have a great day.